So by way of introduction, I'm Carolyn Anderson-Hansen. I'm a physician assistant at Summit Brain, Spine, and Orthopedics. And if you were listening to the presentations yesterday, you know that I'm super strong, shockingly strong. And with the aid of this podium today, you see that I'm shockingly short. Also, I have to mention this. Gary, yesterday in his presentation, commented that he's the peach of the group, but I have it on good authority that actually I solidly hold that title. So today I'm going to talk about cognitive bias, and I hope to make it a little more entertaining and memorable for you by using classic movie clips from my childhood to illustrate these biases. So first, what is a cognitive bias? Cognitive bias can be defined as an error in thinking that occurs while we're processing information from the world around us. It is estimated that we make about 35,000 remotely conscious decisions a day, and that our brain is constantly trying to simplify that process. So these cognitive biases occur when fast or intuitive thinking is replacing analytical thought. Also interesting, we spend 95% of our time in that fast thinking and only about 5% of our time with the analytical process. So when that occurs, it definitely affects our judgment and our decisions. So I think it's also interesting to note that cognitive bias is not the same thing as a logical fallacy. A logical fallacy stems from an error in logical argument, whereas a cognitive bias is rooted in thought processing errors, often arising from problems in areas such as attrition, attribution, memory, and other mental mistakes. So my husband was like, that's a terrible graphic. That graphic, the point of that graphic is to show you that there are more than 100 cognitive biases. So why does this matter? Why does cognitive bias affect us in healthcare? So cognitive bias is pervasive in clinical medicine. And they say that up to 75% of errors in internal medicine can be attributed to our cognitive biases. And numerous retrospective studies have shown that those biases clearly contribute to poor patient outcomes. As I was thinking of examples for this presentation, I thought back on my career of decades in the emergency department and more recently in neurosurgery and orthopedic surgery, and there were no shortage of examples in my own practice and then in practice that I've seen of cognitive bias. So while there are over 100 cognitive biases, today we're just going to touch on 3 that I think are really commonly encountered in medicine. So a Scottish author once said, when men or women wish to construct a theory, when men or women wish to construct or support a theory, how they torture facts into their service. So confirmation bias is when we only consider information or facts that confirm our belief rather than looking for information to refute that belief. So let's look to a cinematic great that illustrates confirmation bias.
We have found the witch, may we burn her?
Who do you know she is a witch?
She looks like one.
Bring her forward.
I'm not a witch, I'm not a witch.
But you are dressed as one.
They dressed me up like this.
And
And this isn't my nose, it's a false one.
Well,
we did do the nose
the nose?
and the hat, but she's a witch.
Did you dress her up like this?
No. Yes.
Yeah,
A bit. She has got a wart.
What makes you think she is a witch?
Well, she turned me into a newt.
A newt?
Got better.
I got better. Burn her anyway!
Okay, I love this one. So in this clip, we see that the people were convinced she was a witch, right? And that wart definitely corroborated their belief, right? So they didn't look for any other information. They actually went as far as to produce illegitimate evidence to support that belief. So while Monty Python is awesome, I think we could look at a clinical example that highlights confirmation bias. So this patient presented to the emergency room, a 32-year-old female with no significant past medical history. She tells the provider that I have a kid at home that's sick, I have a mild cough, subjective fevers, chest pain, shortness of breath, and yes, I'm on some oral contraceptives. Workup in the emergency room revealed a leukocytosis, a white blood cell count mildly elevated at 11,000, a chest x-ray which was read by radiology as nonspecific, possible infiltrate, I'm sure it said clinically correlate, the provider's bias was that this person had an infection, right? And so they were discharged home on antibiotics. Unfortunately, 5 days later, they presented to the emergency room with worsening chest pain, shortness of breath, hypoxia. A CT angiogram pulmonary was obtained, this is not hers, confirming a pulmonary embolus. So in this situation, right, the provider had a bias that the patient had an infection and went with that. And the other evidence that pointed or should have made them a little thoughtful about other possibilities, oral contraceptive use, chest pain, shortness of breath, those were devalued because of the bias. So our next bias is one of the most common and problematic cognitive biases encountered in medicine and in diagnostic errors. This is the anchoring bias. So anchoring bias looks a lot like this horse with blinders on. A clinician locks onto a piece of information and fails to adjust their impression later, much like this horse who focuses on a small portion of the field and is unable to see the broader picture or to change course. So let's see what Lloyd Christmas has to show us about anchoring bias.
I want to ask you a question straight out, flat out. I want you to give me the honest answer. What do you think the chances are of a guy like you and a girl like me ending up together?
Well, Lloyd, that's difficult to say. We really don't...
Hit me with it. Just give it to me straight. I came a long way just to see you married. Just, least you can do is level with me. What are my chances?
Not good.
You mean not good like 1 out of 100?
I'd say more like 1 out of 1,000,000.
So you're telling me there's a chance? Yeah!
I love this clip. So in this clip, we see that Lloyd anchors to the one chance, right? And ignores the 999,999 other reasons why he's never getting that girl, right? Okay, so let's consider a more clinically relevant example of anchoring bias. So a 48-year-old female with a history of osteoporosis presents to her primary care physician complaining of severe back pain. This began after gardening, no significant trauma. X-rays were obtained revealing a vertebral compression fracture. In this situation, the provider anchored to the diagnosis of osteoporosis and didn't create a broad differential diagnosis and entertain other possible causes for this vertebral fracture. Unfortunately, this patient had the diagnosis of metastatic carcinoma was delayed because of anchoring bias. We have time to talk about one more cognitive bias. This is diagnostic momentum bias. I've seen this a lot in my practice. So essentially, this bias is if other people think it, it must be right. And this is dangerous, I think. Like this boulder rolling down the hill, once diagnostic labels become attached to a patient, it's increasingly difficult to remove those and to change course. So let's turn to another iconic film. This is Indiana Jones and the Last Crusade. My husband actually told me that I'm old and maybe people haven't seen this. So to set the stage for you, in this film, a collector is trying to find the Holy Grail. And they use a doctor of archaeology to help with that pursuit. So let's see what happens.
Which one is it?
Let me choose.
Thank you, Doctor. Oh, yes. It's more beautiful than I'd ever imagined.
He chose poorly.
All right. In this clip, the doctor chooses a chalice and the collector doesn't question that choice, right? Indy comments that that chalice would never have been something that Christ had because he was like a humble carpenter and it was so ostentatious, right? But the collector blindly accepted the chalice. So as in medical errors, you could see the outcome was pretty poor for the collector. So let's look to a clinical example highlighting diagnostic momentum. So in this case, a 66-year-old male with a history of atrial fibrillation, not on anticoagulation, presented to the emergency room with multiple falls that day, vertigo, persistent vomiting. While in the emergency room, workup revealed a normal head CT, but the patient was severely dehydrated and admitted to the observation unit. The accepting provider in the observation unit continued with the plan despite numerous red flags in the history and exam. And I think this is important because in medicine, especially when a provider with a higher level of training, education, or position of authority has assigned a diagnosis, someone with less is much less likely to question that and to be thoughtful. So it's a trap we can fall into. Even as we're working with our colleagues here. Thinking like, oh, Dr. Edwards, he would never miss it, right? Never, right? And so, so in this situation, right, the next provider came in and said, this doesn't seem right, ordered MRI brain, and the patient had a cerebellar infarct, which had been missed. So let's review. Cognitive bias. With confirmation bias, we learned that a wart equals a witch. In anchoring bias, we saw how Lloyd anchored to the one chance, right, and ignored the 999,999 other reasons. And in diagnostic momentum, how the collector blindly accepted a chalice without sufficient skepticism. So cognitive bias has been around for quite some time. In fact, in the 18th century, Voltaire said, "The human brain is a complex organ with the wonderful power of enabling man or woman to find reasons to believe whatever it is that they want to believe." Right? So the purpose of today's talk was just to introduce the concept of cognitive bias and to recognize that we all have these biases. How to overcome those biases is maybe a topic for another day, but certainly the first step in overcoming them is recognizing that we have them. Thank you.